may be necessary. And in my opinion, CNI are contraindicated in patients with GFR lower than 60 milliliters per minute. Adrenocorticotropic hormone, ACTH, consists of 39 amino acids. And the first 13 of these amino acids may be cleaved to form the alpha melanocyte stimulating hormone. The synthetic ACTH, which is available in Europe and I think also in Egypt, has the same sequence of 24 amino acids that natural ACTH. In Sweden, Berger and co-workers reported some years ago that they treated by synthetic ACTH 1 milligram twice a week for 1 year, 5 patients with membranous nephropathy and severe nephrotic syndrome. And in 3 patients, they obtained a complete remission of proteinuria, and in the other 2 patients, an almost complete remission with proteinuria ranging around 0.5 grams per day. And this encouraged us to organize a small controlled trial in which patients were randomized to receive the cyclical therapy for 6 months, or synthetic ACTH, 1 milligram twice a week for 1 year. And after a mean follow-up of 22 months, the rate of response was similar in the 2 groups, although there was a trend to have an even higher number of complete remission in patients given synthetic ACTH. And looking at the reduction of mean proteinuria, it was similar in the 2 groups, about 60%. The natural ACTH has also been used by the group of Dr. Appel in New York. And they treated 11 patients with membranous nephropathy. In 3 of them, they obtained a complete remission of proteinuria. In 2, there was no response. And the remaining 6 patients, there was a partial remission of proteinuria. Therefore, we have promising data, but small series with ACTH. We don't have information about the long-term use of this agent. We should take into account that synthetic ACTH may expose to potential side effects, particularly in older subjects, namely diabetes and osteoporosis. At any rate, intact ACTH has been approved by Food and Drug Administration in the US for studies in idiopathic nephrotic syndrome. As you know, the mycophenolate mofetil and sodium mycophenolates are 2 prodrugs that deliver the active compound, mycophenolic acid. And mycophenolic acid is important because it inhibits inosine monophosphate dehydrogenase, which is needed for the novel synthesis of purines and T and B cell proliferation. MMF has been used as monotherapy in a small randomized controlled trial made in France. And at the end of 1 year of treatment at a dose of 2 grams per day, there was no difference in complete remission or in partial remission or in protein creatinine ratio between patients who were treated with MMF and controls treated with symptomatic therapy. 2 other small randomized controlled trials have been published. In Hong Kong, Tom Chan and co-workers treated patients with cyclical therapy or with MMF plus prednisone. And the probability of complete or partial remission was similar in the 2 arms of the study. In India, Nayagam and co-workers compared cyclical therapy with MMF plus methylprednisolone pulses and prednisone, and again the results in terms of remission were similar. In the Netherlands, Branten and co-workers made a historical retrospective study. They compared patients treated with mycophenolate mofetil, methylprednisolone pulses, and oral prednisone with patients treated with cyclophosphamide plus prednisone for 1 year. After a mean follow-up of 23 months, there was no difference in complete or partial remission between the two arms of the study, but the number of relapses after stopping treatment was significantly higher for patients assigned to MMF. Therefore, we have little information about mycophenolate. There is little, if any, efficacy when mycophenolate is given alone. It seems to be helpful in achieving remission when given in combination with glucocorticoids, but frequent relapses are possible. Again, we have little information about optimal dosage, duration, and long-term efficacy. Finally, rituximab. This monoclonal antibody has been used by Dr. Remuzzi in 8 patients for the first time. And in these patients, rituximab was given the standard treatment of 375 milligrams per square meter every week for 4 weeks. And there was a significant reduction of proteinuria. However, the mean levels of proteinuria remained in a nephrotic range, 3.6 grams per day. Fernando Fervenza used rituximab at Mayo Clinic, and he collected information about 20 patients who had proteinuria more than 5 grams per day. And in these patients, rituximab was given at the standard dose of 375 milligrams per square meter every week for 4 weeks, and this treatment was repeated after 6 months. 2 patients didn't respond. In the other patients, proteinuria decreased in mean from 12 to 2 grams per day at 2 years. At the last follow-up visit, 4 patients, or 20%, were in complete remission, 12 patients, or 60%, were in partial remission, 1 patient had limited response, and 1 relapsed. In Boston, Beck also treated 35 patients with rituximab, and in 22 or 63%, he attained a complete or partial remission within 2 years. Of note, the autoantibodies against phospholipase A2 receptor declined or disappeared in 68% of patients within 12 months after rituximab. And generally, the changes in antibodies preceded the changes in proteinuria. More recently, Ruggenti, of the group of Remuzzi, reported the cumulative experience in 100 patients with membranous nephropathy treated with rituximab and followed the mean for 29 months. 27 achieved complete remission and 38 partial remission. And the median time to remission was 7 months. However, 4 patients died and 4 progressed to end-stage renal disease. And in his paper, Ruggenti compared the risk of adverse events in patients given rituximab with patients who were given cyclical therapy in one paper of us. And he reported that apart the first injection, which is often followed by an influenza-like syndrome, rituximab was not responsible of any adverse events, while a number of adverse events were reported by giving the combined treatment. I reviewed the paper of Ruggenti and compared with the paper he quoted before, and looked at the harder point. The mean follow-up was a bit longer in our study. Looking at the probability of total remission, it was 65% with rituximab and 83% with combined treatment. 4% of patients died rituximab-treated patients. No death was observed in that particular paper. 4% versus 2% entered in stage renal disease. A similar risk of cancer was also observed, but of note, 8% of patients in the ESNT paper had cardiovascular events versus 1% in patients given combined treatment. I do agree that it is a nonsense to compare to different studies with different criteria of selection, etc. But since ESNT did this comparison, I also try to see if there is any difference in treatment. My opinion is that rituximab is actually effective in reducing proteinuria. Unfortunately, we don't have long-term follow-up for this agent. It is also still unclear whether patients with renal dysfunction or tubular interstitial lesions can respond or not, since in the previous paper, ESNT reported that they don't respond. There is not any head-to-head comparative study indicating if rituximab may offer results better or comparable to those obtained with steroid cytotoxic regimens, CNI, mycophenolate steroids, or ACTH. So in conclusion, Mr. Chairman and dear colleague, membranous nephropathy is an autoimmune disease triggered by autoantibodies directed against variants of podocyte enzymes. Patients with persistent nephrotic syndrome, kidney dysfunction, or tubular interstitial lesions are at risk of end-stage renal disease. There are a number of different therapeutical options, but with few exceptions, most of the randomized trials are small-sized with short-term follow-up and different definition of remission. Randomized controlled trial with adequate size, long-term follow-up, and fair definition of endpoints are actually needed to identify which is the treatment with the better therapeutic index for our patients with membranous nephropathy. Thank you for your attention.
Thanks, Professor Ponticelli, for this nice presentation. I think time allows for a few questions. I begin first question, please. Is there any explanation for the difference between the response to ACTH, which gave a good response, and the steroids? ACTH alone gave a good response.
I lost your first question.
Okay. ACTH alone gave a good response, while steroids alone in big doses didn't give a response.
Yes, thank you for your question. First, if you can remember the study made in the United States in '78, they used high doses of alternate day prednisone, and they gave for 2 months this treatment. And at the end of 2 months, there was a significant higher number of remission in treated patients than in untreated patients. So apparently steroids were effective. The problem was that after interrupted treatment, most patients had a relapse of the nephrotic syndrome. So looking at the results at 1 year, there was no difference between patients who were given steroids and patients who were not given steroids. To be honest, I think that the statement that steroids are not effective in membranous nephropathy may be wrong. Steroids may be effective, but you have to give high-dose steroids. My feeling is that steroids can be effective, but probably they can also need some reinforcement in order to reduce the risk of relapse. This is why we use steroids plus rounds. But for example, in the second trial we used, we could obtain 40% of remission in patients who had usually this treatment for a number of different cases. First, why do we give causes of physical disorder instead of medicine? Because in a randomized controlled trial we made years before, we compared classical mechanism followed by small doses of oral with the standard dose of oral patients with minimal change of disease. And you could obtain the same number of remission, but lower number of side effects. On the other hand, in the following years, it became evident that even if people with oral toxicity can inhibit the inherent pathway component, which is certainly involved in the pathogenesis of mechanism property and in the lineage of cycles. We decided to isolate steroids and parameters just in order to avoid the toxicity, because within 6 months of therapy, the steroids it can be almost less than. Instead, given 1 month, then they wash out the steroids and then given again steroids could avoid reduce the risk of side effects. And the same is true for parameters. Particularly, I tried to point out that even parameters of cyclophosphamide for 3 months usually is not particularly toxic because the relative low range for cyclophosphamide is about 180 per kilogram, and also for parameters is low. Therefore, the risk of side effects is relatively low, and the side effects that are shown are completely reversible. And the risk of cancer, in our experience, was similar to that of
Okay, my last question, please. You said about you give oral cyclophosphamide 2 milligram per kilo. And this gives you a bigger dose than intravenous 3 shots a month. And the cyclophosphamide may be repeated. And with the side effects, do you think there's a difference between oral and intravenous injections of cyclophosphamide?
Well, this is a general problem, probably also in lupus and in other. I feel that given oral cyclophosphamide is in some way safer. Let me first say, if I had to give cyclophosphamide for 1 year, certainly giving intravenous cyclophosphamide is better because the cumulative dose of cyclophosphamide is lower and the long-term side effects, the risk of cancer, gonadal toxicity, etc., is lower. But if I have to give cyclophosphamide for 1 month and then again after 1 month, it is safer to give oral cyclophosphamide. Because if I give oral cyclophosphamide, I check white blood cells every week in my patient. And whenever white blood cells are lower than 5,000, I halve the doses. If they are lower than 3,000, I stop the use of cyclophosphamide. If I give 1 pass of intravenous cyclophosphamide, I have a nadir after 15 days or so, but this nadir may be 1,000 white blood cells, and the patient is at risk of developing a severe infection. The other point is that, particularly in women, intravenous cyclophosphamide is often associated with alopecia, and at least this is not well accepted usually by patients. But at least in our experience, oral cyclophosphamide worked without any particular problem when given for a short period of time.
Questions from floor?
Thank you, sir. In one of your slides, you have shown us the first trial you have done several years ago. And the two survival curves, the cytotoxic and the placebo curve, started to separate after 36 months. My simple question is, do you find yourself sometimes, or how often does this occur actually, you find yourself able to stop your treatment after 3 or 4 cycles, or sometimes you decide to extend cycles for additional 2 or 4 months? Yeah, I'm sorry, yeah. I'm talking about... Manager Mike, okay. Yes. I'm talking about separation of the survival curves after a long period of time, after 36 months in your slide, first slide. Yeah. This means that you have to give the whole cycle, you have to give 6 cycles. You give your treatment for 6 months. Yeah. Now, occasionally you come across a patient who responds, or he may remit spontaneously after 2 or 3 months. Yeah. And occasionally you ask yourself, should I extend the treatment for additional 2 or 4 months? Thank you. You will.
Beg your pardon, I couldn't understand. The question was if I have an early remission after 2 months or so, is the case of going on for 6 months with treatment? Yes, but I give the treatment for 6 months mainly for trying to prevent the relapse of the nephrotic syndrome. My impression is that too a short treatment may be associated with a remission that is not definitive. What we try to obtain is a long-term remission. But I take your point. In the case of some side effects, of course, I can stop completely treatment.
Thank you, Professor Boncelli, for this excellent talk. For the sake of time, we are going to shift now to the third speaker. Third speaker is Professor Simon Davis. He is a professor of nephrology and dialysis medicine in the Institute for Science and Technology in the Medicine at Keele University. Also, he is one of the members of the United Kingdom Renal Registry Dialysis Group, and he is also the chair of the International Society of Peritoneal Dialysis Research Committee and the associate editor of Peritoneal Dialysis International Journal. Professor Simon Davis are going to speak now on the new peritoneal dialysis solution. Where are we?
Thank you for the kind introduction and the invitation to speak today. So I've been asked to talk or give you an update on where we are with peritoneal dialysis solutions, and I'm going to focus on 3 main areas. I'm going to focus on solutions that have been developed to reduce the risk of membrane injury. And these are by and large solutions which have a low glucose degradation product content, and also solutions that have a normal pH. And in that case, I'm going to talk specifically about the BALANCE trial, which was published earlier this year, which is the largest randomized controlled trial that's been used in this sort of solution. I'm then going to talk about where we are with solutions that have been designed to increase sodium removal in peritoneal dialysis patients. I'm going to update you on the Deltasol pilot study, which I was a partaker in, which was evaluating a new low sodium solution, and tell you where we're going with that in terms of the next trial. And then finally, I'm going to talk to you about solutions which have been designed predominantly to improve the metabolic complications of peritoneal dialysis, particularly the opportunity to reduce the glucose load to peritoneal dialysis patients. And I'm going to update you in the yet unpublished study, Impendia Eden study, which is a Baxter study looking at alternatives to glucose, in other words, icodextrin and amino acid solutions in combination. So let's first of all talk about the issue of membrane injury. And before I talk about the BALANCE study in more detail, I would like to just update you with what we understand currently about the progression of membrane damage that occurs with time on peritoneal dialysis treatment. First of all, we should say that we know that at the start of peritoneal dialysis treatment, there is a huge variety in membrane function. Patients have very different membranes. They have different amounts of solute transport rates. So some patients have a large membrane with high solute transport, and we now know that that is associated with the local production of IL-6 within the peritoneal cavity. We also know that there are other differences. For example, some patients have different membrane efficiencies, and Olivier Devoist does some interesting work showing that polymorphisms associated with different aquaporin expression are also present and determining the membrane function at the start of treatment. We then look with time on therapy. Many patients will remain stable for many years on therapy, particularly if there's been a low glucose load to the peritoneal membrane. But the first change that we can observe is there's an increase in the peritoneal solute transport characteristics of the membrane. And we believe that is due to an increase in the vascularity of the membrane, number of vessels, and possibly also an increase in the blood flow that happens in some patients. After a period of time, usually more than 3 or 4 years on treatment, you can then get a more serious type of membrane injury, which is associated with dissociation of the solute transport increase and the efficiency of the membrane. The osmotic conductance of the membrane starts to fall, and in that situation we believe that there's a more serious type of membrane injury occurring, which is associated with progressive fibrosis. And then subsequently, those patients are more likely to go on and develop ultrafiltration failure. And in a very small proportion of those, but it is definitely a risk factor for that, then those patients can also subsequently get encapsulating peritoneal sclerosis. So that is what we believe to be the cascade of events that happens. And I want to emphasize that the speed with which patients travel down this pathway is very different. But one of the main predictors of that speed is the local exposure to glucose of the membrane, and also, by definition, the more glucose you have in conventional solutions, the more glucose degradation products. So the question which we really wanted to know the answer to is, if we have solutions that have no GDPs present, then could this potentially reduce the development of membrane injury? And the first studies that looked at low GDP solutions really were looking at biomarkers within the peritoneal membrane. And the study I want to refer to here is the EuroBalance study. This is a study that was published back in 2004, where the solution tested, which is the BALANCE solution produced by Fresenius, which is a very low GDP solution, which is pH neutral, but still uses lactate as its buffer. And in that study, they showed in their primary endpoint that there was a reduction in the dialysate concentration of some biomarkers associated with membrane injury, and also an increase in CA125, which is thought to be a sign of mesothelial cell health. So this was, if you like, a proof of principle study suggesting that these biocompatible solutions did result in less local membrane injury. But during that study, they also noticed 2 other things happening. And just to remind you of the design of this trial, it was actually a crossover study, so some patients started on Stay Safe and switched to BALANCE, and other patients switched from BALANCE to Stay Safe. And they made a couple of other observations. First of all, that when you were on the BALANCE solution, the biocompatible solution, was actually an increase in the solute transport characteristics of the membrane, which seemed to be reversible. So when people went from BALANCE to Stay Safe, that went back to the previous value. That increase in solute transport was also associated with a reduction in the ultrafiltration capacity of the membrane. So actually the membranes became less efficient at ultrafiltrating. And at the same time, there was also relative preservation of residual renal function. So those patients, whilst on the BALANCE solution, tended to have better urine output compared to the patients on the Stay Safe. Although the total fluid removal, the ultrafiltration plus the urine volume was the same. So the purpose of the balance study was really to try and understand, so the balance study, that was the balance study done in Australia and New Zealand, was really to try and understand what these processes were. So this is a relatively large randomized control trial of new PD patients, 90% of whom were starting on CAPD, so this is really not an APD study. The primary endpoint of this study was the rate of decline of residual renal function. And the reason for that was chosen was because of this previous observation in the Eurobalance study that balance solution might be associated with better preservation of residual renal function. But they also looked at other endpoints. They looked at time to anuria, they looked at peritonitis rates, and they also, of course, looked at membrane function longitudinally. And this was a 2-year follow-up study. They assessed more than 500 patients for the study and actually had difficulty in enrolling enough patients for their predicted primary endpoints. So in fact, it was an under-enrolled study, although they did have a significant result at the end of the studies and in terms of the analysis, which was undertaken in 167 equally randomized patients. So what I'd like to do, first of all, is to look at the changes in membrane function that were observed in this study. So what you see here in the next few slides is the comparison of the patients randomized to the balanced solution, which is shown here, compared to the green, which is the controlled stay-safe solution. And you can see that after 1 month of starting the new solutions, after randomization, that there was already a significant difference in membrane function right at the start of treatment. And this echoed the observation that was seen in the Eurobalance study, which showed that the patients randomized to the balanced solution had a higher solute transport characteristic at the start of treatment compared to the control group. That was statistically significant at 1 and again at 6 months. However, what was new compared to the Eurobalance study was now the longitudinal follow-up of those patients. So now what you see is that the patients that were randomized to the balance have very stable membrane function, absolutely no change occurring over a 2-year period, whereas those randomized to the regular glucose solution had this steady increase in solute transport, the sort that we've usually seen in patients with progressive membrane injury on PD. That difference in membrane function at the start of treatment was associated with differences in the ultrafiltration capacity of the membrane. So as you would expect, patients who have higher solute transport, as in the balance study, they tend to have less good ultrafiltration capacity. This is partially because they're absorbing the glucose more rapidly, but there does seem to be something more to that when you do the full analysis of this study. So these patients had less efficient membranes at the start of the treatment in terms of ultrafiltration, although this became equal in the second half of the study. And this translated into different amounts of ultrafiltration that were achieved. So again, what we see is that the patients randomized to the balanced solution for the first year of this study achieved less ultrafiltration despite the same glucose concentration. So this is normalized for their glucose exposure compared to the patients using the stay-safe solution. And although this may not look like a big difference to you in terms of achieved ultrafiltration, we must remember that dialysis bags are overfilled, so you should actually correct for that when you do the calculation. So actually, in fact, in terms of net ultrafiltration achieved, these patients randomized to the balanced solution for the first year of treatment were getting about half the amount of ultrafiltration achieved in the regular solution. Although by the time we get to the end of the study, this is the same. This is because of the changes in longitudinal membrane function. So these patients were getting less ultrafiltration. What happened to their residual renal function? Well, here we see that, again, throughout the first year of the study, the patients randomized to the balanced solution had better preservation of residual renal function, actually with a rather similar difference in terms of fluid removal compared to the differences in ultrafiltration achieved in the previous slide. And that then after 1 year of treatment, that essentially equalized. And this translated into delay in the time of anuria that was seen in the balanced solution patients. So here we see that during the course of that 2 years, very few of the patients became anuric in the balanced study, in the balanced group, whereas in the stay safe group, there was a more rapid transit to becoming anuric. So we were getting preservation of residual renal function in the context of less ultrafiltration. The other important endpoint in this study was the peritonitis endpoint. This was not necessarily predicted, but it's actually very significant and very encouraging. So what you can see here is that time to the first peritonitis episode in the patients randomized to the balanced solution was much longer compared to the stay-safe solution. And actually, in addition to that difference, also the episodes of peritonitis themselves were less severe. They were treated more quickly with a more rapid resolution of the inflammatory process. So what have we learned from the balanced study? Well, first of all, it definitely confirms the Eurobalance observation that these two different solutions have a different immediate effect on the membrane. It does seem that the more biocompatible solution, and this has been seen with other biocompatible solutions as well, that when you use a more biocompatible solution, you tend to have a slightly higher solute transport rate. And we can only hypothesize as to why that might be, but it could be, in fact, that because the biocompatible solution is less cellular toxic, then those cells within the peritoneal membrane which are able to produce IL-6, which is the main determinant of solute transport, are actually healthier, and therefore you get a slightly higher production of local IL-6 within the membrane. Is that a bad thing? Well, not necessarily, because if the membrane then subsequently becomes stable and does not change over the next 2 years, I would argue that is a safer and better outcome than the original non-GDP-containing solutions. So I would say that this also has demonstrated that GDP exposure is one of the factors that's driving longitudinal membrane injury. And although it's only that very first stage in membrane damage that we're seeing a benefit for, I'm encouraged by that as an observation. We cannot say at this stage whether the subsequent membrane fibrosis is going to be affected, because this study has not been long enough to follow up the patients to see that effect. And that's one of the difficulties in these studies that we've been having, is that in order to recruit enough patients to see effect on membrane fibrosis, you have to do a very large and very long study. We've also found that they also found that this relative preservation of residual renal function in these patients randomized to balance, and I would argue here that the mechanism of this is probably because these patients had less ultrafiltration. And you could argue that what they've done here is also a randomized controlled trial looking at what is the optimal amount of ultrafiltration that we should be achieving in patients. And I would suggest to you that what this study is showing is that in the early stages of peritoneal dialysis, there is actually no strong argument for driving ultrafiltration, because these patients who had less ultrafiltration had better preservation of residual renal function, and yet their overall outcomes in terms of survival, in terms of blood pressure control and other factors were no different. So I think there's an important lesson to be learned from this study in terms of how we manage patients more generally in PD. And finally, there was this important reduction in peritonitis, which is, again, I would suggest something to do with improved health of the peritoneal membrane. So what I'd like to do now is to move on and discuss where we are with low sodium solutions and tell you a little bit about the DeltaSol pilot study that I was involved with. So first of all, I'd like just to think with you what is the purpose for having a low sodium dialysis solution. What we really want to be able to do with peritoneal dialysis patients when we're achieving ultrafiltration is also to get a good sodium removal, particularly in patients who are hypertensive. So the ultimate goal, is to get more sodium out of the patient for a given glucose load. And because of the basic anatomy or the biology of the peritoneal membrane and the fact that ultrafiltration comes through two different pathways, through the small pore pathway, which is the intercellular clefts, and through the aquaporin pathway, which is a water selective channel. When we increase our glucose concentration in dialysis fluid, then what we get is, relatively speaking, more ultrafiltration occurring through the aquaporin pathway, which is a sodium-free pathway removal. So all the time, PD patients are at risk of, if you like, getting out more water than they are sodium. So one of the other purposes of a low-sodium solution is to try and reduce this gap between the sodium and the water removal. And then finally, the purpose is to increase the overall sodium removal sufficiently to allow the patient to have an adequate sodium intake, but not, and I repeat, this is not the purpose of these solutions to simply get as much sodium out of the patient as possible so they have a completely free diet. We still believe that even using a low sodium solution, that some degree of sodium restriction is necessary. And it's perhaps worth just thinking what we believe a adequate sodium removal or sodium restriction might be for peritoneal dialysis patients. We certainly know from many observational studies that if you have a sodium intake on peritoneal dialysis of less than 5 grams of salt per day, then actually that is associated with a substantially worse clinical outcome, almost certainly due to the fact that these patients are inadequately nourished and essentially not eating well on dialysis. Equally, it seems sensible to try and avoid too much of a salt intake, and certainly more than 6 or 6.5 grams of salt per day is something that we would not recommend, not least because you then have to get a lot of ultrafiltration in order to achieve adequate sodium removal. So what we're aiming to do is to get the sodium losses somewhere between 80 and 100 millimoles of sodium per day. So how do we go about designing a low sodium solution? How does this work? Well, first of all, you can see here ultrafiltration curves, or perhaps I should call them sodium removal curves, that you get with time of a dwell according to the glucose concentration. And what you can see here is because the sodium concentration in the regular dialysis solution is just very close to plasma, when you have a solution which is getting very little ultrafiltration, for example, a 136 solution, but essentially that solution is sodium neutral. So when you're using a 136 or low glucose concentration bag in a PD patient, you're essentially going for a sodium neutral exchange, unless you use a short exchange in APD patients. That's quite different to the ultrafiltration curves. And just to illustrate this point a bit more, I have to put my glasses on so I can see. What this shows you here is how the amount of sodium that you remove from a single 136 glucose exchange will change according to how you adjust the sodium concentration in the dialysis solution. So here's the regular solution showing essentially no sodium removal, but as you remove the sodium or reduce the sodium concentration in the bag, because of diffusion of sodium, you now get a much more effective sodium removal. So you can see here, for example, for 120 millimoles of sodium, that you would typically get about 20 millimoles of sodium being removed using a 136 exchange. But there is a problem here because sodium itself is an osmotic agent. So when you reduce the sodium concentration of the bag, then what you get, unfortunately, is less ultrafiltration. So in order to get the same amount of ultrafiltration, you have to increase the glucose in the solution to compensate for the reduction in the osmolality. And this graph here shows you that sort of effect. So you can see here that here's a 132 exchange. If we're going to get the same amount of ultrafiltration from a 136 exchange, we'd have to increase the glucose concentration up to around about 1.7%. So in the deltazole study, what we did was to look at actually two different solutions. We initially planned to look at 3 different solutions, but I'm only going to concentrate on these 2 left-hand solutions here, one here called A plus C, and here called B plus C. And this was originally developed with Gambro when they were in the PD market, but this has now been taken over by Fresenius, and they're continuing to work with us on this project. And these two solutions essentially were different because of what we did to the glucose bag. So here's a standard solution below using a 1.5% glucose and 133 millimole sodium concentration. And we compared that with a sodium concentration of 115, but we increased the glucose in this solution to make sure we maintained some ultrafiltration. So they went to a 2% exchange. In this solution here, on the solution B, we looked at a comparator to the regular 2.5% glucose exclusion. We kept the glucose concentration the same, but we much reduced the sodium down to 102. But we did not compensate by increasing the glucose solution. So what we expected to see in this solution would be better sodium removal, but less good ultrafiltration. And the study we did to look at those two different solutions was essentially a very simple before and after study. What we did is had a run-in period of a month. We then exposed patients to the new solution for 2 months. We measured a number of different things, including blood pressure, bioimpedance measurements. We also looked, we did a deuterium dilution measurement, and we also looked at thirst in these patients using a self-reporting system. It was an open-label study, and it was in 3 centres in the UK and Sweden. And this is the sodium removal we had achieved. First of all, in the black bars we here see is what we predicted would happen according to the way we designed our solutions using the 3-pore model as our designing process. So what we can see in solution A, which you'll remember is the compensated solution. So it's 150 millimoles of sodium with some extra glucose in the 2% glucose. We expected to see a significant increase in the sodium removal, and when we actually measured that, we indeed saw that patients were having virtually no sodium removal of that solution before intervention, which then increased to around about 25 millimoles of sodium extra being removed. When we looked at solution B, which was the non-compensated solution, again we saw this increase in sodium removal as predicted from the 3-pore model. So we were getting more sodium removed from the patient, but as predicted, those patients got less ultrafiltration. We then compared those solutions in terms of how they resulted in differences in different clinical outputs, and I'm just showing you a couple of examples of this. We looked at blood pressure, and you can see that when we looked at the compensated solution, this is the 2% 115 millimole sodium solution, we saw following entry into the study that there was a significant fall in the systolic blood pressure, both actually during the day and the night, but it was more marked during the night time. In contrast, the solution that was not compensated, in other words, these patients lost ultrafiltration but had better sodium removal, their blood pressure did not change at all during the course of the study. When we looked at the effects of these two different solutions on body composition, we again found very different patterns. So in the group A solution, this is the compensated solution, we found that there was a reduction in total body water using bioimpedance, also using deuterium dilution, and we also demonstrated that there was a reduction in the extracellular fluid volume using the bioimpedance methodology. So it would appear that this solution is having an effect on both blood pressure and body composition, whereas the solution B, which was not compensated, actually had no effect at all on body composition, and if anything, there was a slight increase in the patient's weight during the course of the study. So what did we conclude from this study? Well, it appeared that we could indeed develop a low-sodium solution that resulted in better sodium removal for the amount of glucose exposure, which was our primary objective. We were also able to show in this open-label study that provided the amount of ultrafiltration was maintained using the compensated solution, but an increase in the net sodium removal could be associated with both an improvement in the fluid status the blood pressure, and I haven't shown you the data, but also these patients reported less in the way of thirst. So that is the solution that we are taking forward in the next study, which is now underway. This is a multi-center study across Europe looking at that compensated solution. It's a randomized controlled trial with blood pressure, arterial blood pressure as the primary endpoint, but we're also looking at body composition and fluid status